Welcome to the Physiology Case Scenarios Cardiovascular Series 6. This video discusses a case of aortic stenosis, the normal and the altered hemodynamics in the coronary perfusion in aortic stenosis. The case scenario is this. A 34-year-old woman who complains of syncopal attacks and shortness of breath gives a past history suggestive of rheumatic fever and arthritis. On examination, the pulse rate is 70 beats per minute, regular, blood pressure 100 by 80 mm mercury, carotid pulse is slow rising and sustained, precordial examination reveals heaving apex beat, a systolic thrill, a mid-systolic murmur at the aortic area. A tentative diagnosis of aortic stenosis is arrived at. ECG shows evidence of left ventricular enlargement, inverted T waves in lead 3 and AVF. Left heart catheterization records show a large gradient between the left ventricular pressure and the aortic pressure during the rapid ejection phase, with elevation of peak left ventricular pressure around 160 mm mercury. So this is the case. Let us see what is the question or what are the questions. Question 1. The large pressure gradient between the left ventricle and aorta during the rapid ejection ensures which of the following? The options are filling of the left ventricle, flow of blood into the aorta, aortic valve closure, aortic valve opening. The answer must be the flow of blood into the aorta, because in aortic stenosis there is a resistance offered by the stenosed wall. So blood finds difficulty in entering the aorta. Normally, a small pressure gradient is enough to cause the blood to flow into the aorta from the left ventricle due to the forceful ejection of the left ventricle. In aortic, because of the resistance offered, the normal flow is ensured by a larger pressure gradient. Normally, in the rapid ejection phase, the left ventricular pressure is slightly greater than aorta. There is very small gradient. In the reduced ejection, the aortic pressure is slightly greater than the left ventricular pressure with a very small gradient. But in aortic stenosis, as we see later, there is a large pressure gradient. It ensures the near normal flow of blood into the aorta. Now let's see what explains the large pressure gradient between the left ventricle and aorta in aortic stenosis. This leads us to some of the basics. Flow is equal to pressure gradient by resistance. Therefore, the pressure gradient is equal to flow times resistance. So when the resistance is high or increased, as in aortic stenosis, to ensure the normal flow, the pressure gradient has to increase. The increased pressure gradient in the face of resistance ensures near normal flow in the initial stages, not in the later stages. Flow will fall. Let's go on to the pressure curves, aortic and ventricular pressure curves or pressure tracings in a normal individual on the left side. On the right side, the same is in aortic stenosis. The green, the larger one, is the left ventricular pressure, and the blue is the aortic pressure. Normally, you can see the phases of a cardiac cycle. You can imagine the left ventricular pressure steeply rises in the isovolumetric contraction phase till it reaches the aortic diastolic pressure, and the aortic valve opens and the left ventricular pressure rises again due to the systole. Aortic pressure also rises along with the left ventricular pressure with a very small gradient. Aortic pressure slightly less than left ventricular pressure, as you see. The blood flows into the aorta from the ventricle. Both the pressures rise to the peak of nearly 120, and then during the reduced ejection phase, both aortic and left ventricular pressure fall. But in this case, the aortic pressure is slightly greater than left ventricular pressure, and there is hardly any gradient during the ejection phase. Now look at the aortic stenosis. Brown shaded area is the gradient, large gradient between the left ventricular pressure and the aortic pressure, especially during the rapid ejection. And the aortic pressure, you can see that the peak is reduced. Left ventricular pressure peak is increased, maybe 116, as in the case. Aortic pressure has fallen to say 100 because the blood pressure was low, and this has created a gradient, and the aortic pressure is very slowly rising, not steep as in normal. Slow rising Sometimes the dicrotic notch is less prominent. One more feature in aortic stenosis is the anacrotic notch in the ascending limb. So this is how the aortic or carotid pulse looks like in aortic stenosis. But the prominent feature is the large pressure gradient. Case 2. In the case of aortic stenosis, the left ventricular enlargement, as we have seen in the case, is an adaptive mechanism to maintain the stroke volume. This hypertrophy has which of the following effects on the heart? It decreases the myocardial oxygen consumption, it increases the myocardial wall thickness, increases the systolic wall tension, dilation of the left ventricular chamber. In aortic stenosis, as the disease advances, the left ventricle will enlarge as an adaptive mechanism to maintain near normal stroke volume. That means the cardiac chambers thicken by increased hypertrophy, increase in the size and number of cells. So this increases the myocardial thickness. So B is the correct answer. In fact, it increases the myocardial oxygen consumption because of the increased muscle mass. A is not the correct answer. It decreases the wall tension, as we see in the next again. C is not the correct answer. And initial stages, it does not cause dilation of the left ventricular chamber. Answer is myocardial wall thickness increases. So in aortic stenosis, there is a compensatory left ventricular hypertrophy that causes the increased wall thickness. According to Laplace law, wall tension is equal to pressure times radius divided by thickness, h. So in this case, when the thickness increases as an adaptive mechanism, for any given pressure or radius of the chamber, the tension of the T decreases. So when the wall tension, which amounts to the afterload to the left ventricle, also is reduced. And when the afterload is reduced, stroke volume is maintained. The increased left ventricular muscle mass and greater interventricular pressure increases the myocardial oxygen and predisposes the individual to myocardial ischemia. Dilation of left ventricular does not occur. 3. This patient's ECG shows signs of inferior wall myocardial ischemia, as evidenced by the inverted T waves in lead 3 and AVF. Which of the following factors make the individuals with aortic stenosis more prone to develop myocardial ischemia? Is it increased aortic systolic pressure? Is it increased myocardial oxygen consumption? Is it lesser compressive force on coronary arteries? Or is it decreased left ventricular end diastolic pressure? As we have already seen, the increased wall thickness increases the myocardial oxygen consumption. There are several other factors also which make the person prone to develop ischemia, but here the myocardial oxygen consumption is an important factor. Aortic wall systolic pressure does not increase, only the left ventricular pressure increases. So A is not the correct answer. Aortic systolic pressure may be normal or it is reduced. Compressive force on coronary arteries will be more because of intraventricular pressure greater. So there will be more compressive force. So C is not correct answer. Left ventricular end diastolic pressure will not decrease. It will start increasing because of the decreased stroke volume as this disease advances and the increase in systolic volume and pressure. So there will be increased left ventricular end diastolic pressure. D is not the correct answer. In the initial stages of aortic stenosis, left ventricular wall thickness increases as an adaptive response to maintain the contractile force and stroke volume. Later, left ventricular end diastolic volume and left ventricular end diastolic pressure also increase on account of greater end systolic volume. In this setting, the most likely cause of decreased coronary blood flow are, as I said, MVO2, increased oxygen consumption, especially when there is an increased demand as exercise, greater compressive force on coronary arteries, decreased capillary density relative to the wall thickness. Normally there is a large capillary density, but when the thickness increases, this density will not compensate for the thickness. Elevated left ventricular end diastolic pressure reduces the coronary perfusion gradient, especially in the diastole, where most of the coronary flow occurs to the left ventricle. And also later stages when the aortic systolic pressure reduces, the perfusion pressure reduces, and especially to the right ventricle during the systole, where most of the flow occurs. So these are the causes of decreased coronary blood flow in aortic stenosis. 4. One of the factors that contributes to the ischemic manifestation of patients with aortic stenosis is the severe compression of coronary artery branches due to high intraventricular systolic pressure, in this case 160 mm mercury, and the reversed pressure gradient for coronary flow during the systole, because the aortic pressure will be less ventricular pressure will be high, so pressure gradient is reversed. In fact, the question is this: the normal pressure gradient for the flow to occur to the right ventricle during the ventricular diastole is how much? Is it 120 minus 25, 95, 80 minus 0, 80, 80 minus 25, 55, 25 minus 0, 25. To answer this, we have to see what is the pressure gradient to the right ventricle during the diastole. So during the diastole, the aortic pressure is reduced to say 80. Not in this case, probably, yeah, in this case also it was 100 by 80, yes, 80. And the right ventricular diastolic pressure is near 0. So the best answer is 80 minus 0, 80. To explain, you will see an image. The coronary flow, how it occurs in left ventricle in systole and diastole. Left ventricular systolic flow is very, very low. In this case, it is reversed. Pressure gradient is nil here because aortic pressure is 120, systolic aortic pressure. Left ventricular pressure normally also 120, so pressure gradient is 0. So no flow occurs to the left ventricle, or the coronary artery is supplying the left ventricle in systole. Most flow occurs in diastole, nil flow occurs in systole. This is called the phasic flow. In diastole, aortic pressure falls to 80, but left ventricular pressure falls to almost 0 or 1 or 2, a couple of millimeter. So pressure gradient is 80. So for the flow to occur in the coronary artery supplying the left ventricle occurs only in the diastole. Let's look at the coronary flow in coronary artery supplying the right ventricle. In systole, aortic pressure is 120, right ventricular pressure, peak pressure is 25, but there is enough pressure gradient of 95. So the right ventricular coronary flow occurs as per the aortic pressure. It follows the perfusion pressure. 95 is there. In diastole also, it is 80 minus 0, as we have seen in the case. Aortic pressure falls to 80, right ventricular pressure near 0, it is 80. Phasic flow is not seen in the right ventricle, only in the left ventricle. 6. The following images compare the pulse tracing of normal adult male and that of the patient described in this clinical scenario, that is the B. What is the cause of the notch in the arrowhead? Dicrotic notch, which is less prominent in aortic stenosis. You can also see an anacrotic notch, the anacrotic type of pulse with a decreased pulse pressure in B, aortic stenosis. Pulse pressure is 40 in A, much less, nearly 20 or so. If you look at the options, the correct answer must be A. Here there is a small amount of blood from the aorta coming back towards the ventricle because of a falling ventricular pressure and the pressure gradient creating the blood column to come back. And this will close the aortic valve and the blood column gets reflected black, causing this slight hump. So this is the dicrotic notch. The arrowhead points to dicrotic notch. So it must be the answer A. This is question 7. Which of the following factors has contributed to the systolic murmur in this case? High velocity of blood through the stenosed valve, increased resistance offered by the impedance to flow, high left ventricular peak systolic pressure, increased left ventricular wall tension. The systolic murmur is due to the turbulence during the systole, during the ejection, due to large amount of resistance to the flow. But the murmur as such is not due to the resistance. It is due to the high velocity caused by the resistance. So the answer must be high velocity. The normal blood flow is laminar or streamlined. As you can see in this diagram, the turbulent flow occurs when the velocity is very high or when the viscosity is very low or when the vessel diameter is large. So the viscosity, velocity, diameter and the density affects what is known as the Reynolds number, and which is the probability for turbulence. In this case, the turbulence due to high velocity of the blood through a narrowed or stenosed valve. Let's see why high velocity. Velocity is flow divided by cross-sectional area. So greater the cross-sectional area, less will be the velocity of the blood. So in areas where total cross-sectional area is very large, as in capillary blood, velocity of blood is very less. When aorta, the cross-sectional area is less for a given flow, that's our output or stroke volume, the velocity is high. So in this case, the cross-sectional area has been reduced by the stenosis. Velocity increases for a given amount of flow.